Welcome to the Insights at ACR 2020 series, brought to you by the Cytokine Signaling Forum, where authors reviewed their Congress posters and presentations on cytokine signaling and JAK inhibitors. My name is Professor Chris Edwards from the University Hospital Southampton in the UK. This edition focuses on vaccinations and features presentations from Professor Kevin Winthrop and Dr. Rodriguez-Garcia. An elevated signal of herpes zoster has been observed across the JAK inhibitor class. In our first presentation, Professor Winthrop summarizes the incidence and risk factors for zoster in patients with RA receiving upadacitinib.
Hi, it's Dr. Kevin Winthrop. I'm a professor of infectious diseases and public health here at Oregon Health Science University in Portland, Oregon. We calculated herpes zoster incidence rates per 100 patient years. We'll note that the majority of patients were using background methotrexate in this analysis, and about half the patients were using steroids across the various dosing groups. In terms of the presentation of zoster, it's really no different than what we've seen with other JAK inhibitors. Almost all these cases are cutaneous. Most are monodermatomal or limited to a second adjacent dermatomal or dermatome. Invasive cases are extraordinarily rare. There was just one in this experience where one patient on 30 milligrams once daily developed meningoencephalitis. And other than this case, there were no other CNS or other invasive cases. The Kaplan-Meier curve is nice to look at. You see that the higher incidence really starts right away with the 30 milligram group as compared to the 15 milligram group. And the rates were obviously much higher for the 30 milligram group than they were the 15 group. In terms of risk factors for herpes zoster, I thought this was really a nice analysis. What was interesting to me is that the history of zoster stuck out as a very strong risk factor. This was a bit counterintuitive. Normally when someone has an episode of zoster, they build their immunity. It's like vaccinating yourself, and this lasts for some time, and most people don't develop a second episode in their lifetime. So what was interesting to me is that this was actually the strong risk factor. I would have guessed that people with prior history would have been relatively protected. But that's not the case. So this is intriguing, and I think it makes me want to investigate this further as to why. But that was the strongest risk factor for developing zoster while receiving upadacitinib. The other risk factors were enrollment in Asia, and this is something we've seen in the other JAK inhibitors as well, that there is something special about being in Asia, and that your risk factors are higher. And it's probably multifactorial in terms of why that's happening, but we just don't know. We did not really see much increased risk associated with age in this analysis, slightly higher rates in older people, but we really should have seen higher rates than we did probably, as we know that is a very important risk factor for zoster. What was interesting here is that we didn't see an increased risk with background corticosteroid use. That's of course been noted in pretty much every zoster study ever, ever done on the planet. It is a very strong risk factor for shingles. So why we saw nothing here, I don't know. Maybe it's just too small of an experience, or the doses were small enough. I just don't know. But I was surprised to see it not wash out as a significant risk factor in this analysis. So in conclusion, herpes zoster events in patients with RA receiving UPA were higher in 30 as compared to 15. The rates with 15 were fairly similar to the rates we see with other JAK inhibitors in their developmental programs. We certainly see the same risk factors with regards to patients in Asia being at higher risk, the reasons for which, again, we don't know. And what, again, what stuck out for me here as being interesting was the history of shingles as being a marker for a higher risk of having shingles while undergoing JAK inhibition in this experience. So that deserves further follow-up. So that's it. Thanks very much for your attention. Have a great Congress. Cheers.
We'll be hearing from Professor Winthrop again in a moment, But first, a presentation from Dr. Rodriguez-Garcia on the real-world impact of the combined vaccination scheme against Streptococcus pneumoniae in patients with RA treated with DMARDs.
Hi, I'm Sebastián Rodriguez-Garcia. I'm a rheumatologist. I currently work at La Princesa University Hospital in Madrid, and I'm going to present our work regarding the impacts of the pneumococcal combined vaccination scheme in the incidence of related infections. For this work, I had help from my colleagues from many different tertiary centers across the country, but most of all from my colleagues from the research units on the Spanish Rheumatology Society. So I'd like to thank all the hard work, and I would like to acknowledge their work. So regarding the abstract, I will start by giving some background. And we know that respiratory infections are among the leading causes of hospitalization in RA. And these respiratory infections are, I'll say most of the time, related to some certain bacteria, and among them, Streptococcus pneumoniae is one of the most frequently involved. And for that, vaccination is strongly recommended in this group of patients to try to reduce the incidence of related infections. Regarding vaccination for pneumococcal disease, the Spanish Ministry of Health currently recommends the combined vaccination scheme, that is, 1 dose of the conjugated vaccine, and after that, 8 weeks after that, one of the polysaccharide, and 5 years from this last one, another dose of the polysaccharide vaccine. So the evidence supporting this recommendation derives from other at-risk populations, such as HIV cohorts or cohorts of asplenic patients, for instance. So there's only few studies analyzing the real impacts of these vaccination protocols in clinical practice. So that was the gap of knowledge we were trying to fill with new evidence. So our objective was to assess whether the implementation of this combined vaccination scheme has the expected impact on the incidence of Streptococcus pneumoniae related infections in patients with rheumatoid arthritis treated both with biologic or targeted synthetic DMARDs. For that, we our study design was we nested a cohort of RA patients on a national prospective register. This register includes patients treated with biologics, either naive or switch, and also with targeted synthetic DMARDs. The period we analyzed goes from October 99 to November 2018. And to assess vaccination status, the vaccination administration is not a thing that we systematically collect in this register. So to assess the vaccination status, we surveyed all participant centers regarding their vaccination policies, and including the date of the initiation and of the implementation of the systematic scheme, and which scheme they use. So after that, we set 3 outcomes that we believe that are tightly related with pneumococcal disease. Those outcomes are invasive pneumococcal disease, that's one of the obvious one. Community-acquired pneumonia, not necessarily bacteremic community-acquired pneumonia, but also we included lower respiratory tract infections, because in the literature it's quite clear that the burden of pneumococcal disease might be underestimated if we only go for invasive pneumococcal on bacteremic community-acquired pneumonia. So we gather a set of codes. We use codes from the Medra dictionary in the register to analyze adverse events. So we gather sets of codes for these 3 outcomes. And then for the last model, for the regression models, we use a composite outcome, adding those 3 outcomes that I mentioned. And the new one, the composite, was called SP-related infections, Streptococcus pneumonia related infections. So we obtained the crude incidence rates, and we split the exposure periods, the total exposure in 2 periods, a pre-vaccination and a post-vaccination period. And the time point to split this exposure was 2016, because that was the time when the combined scheme was officially recommended in Spain. And then we built a Poisson regression model adjusting for potential confounders such as sex, age, smoking, and the Charleston's index to estimate the incidence rate ratio comparing both periods, the pre and the post-vaccination ones. So regarding the sample we obtained, we included 1,704 patients. The mean age was 60 years old. 79% were female, and around 70% were currently smoking when they were included in the register. The mean disease duration was around 9 years, and around 75%, 77% were positive for rheumatoid factor and were ACPA positive, respectively. So regarding the incidence rate, we presented the incidence rates per 1,000 person years, and we obtained a total of 167 events. That was the overall amount of events. And on the pre-vaccination period, we obtained no events for invasive pneumococcal disease, but we obtained a number of events for community-acquired pneumonia and also for lower respiratory tract infections. So the incidence rate for community-acquired pneumonia in the pre-vaccination period was 21.8 infections per 1,000 patient years, and it was further reduced to 14.6 on the post-vaccination period. And when we analyzed the composite outcome, the pneumococcal related and Streptococcus pneumonia related infections, the total incidence rates on the pre-vaccination period was 31.9 events per 1,000 patient years, and it was reduced in the post-vaccination period to 17. So when we split this incidence rates by age, and we use the frequently used time points at 65 years old, we see that, as expected, patients older than 65 years old have a higher incidence rate. That was 47.1 for SP-related infections, and it was further reduced to 34.6. And the similar thing happened when in patients that had less than 65 years old, but the incidence rates we got lower incidence rates. It was 29.5, but it was also reduced to 14.2. That was for the outcome SP-related infections, the composite outcome. Regarding the Poisson regression models that we built, we obtained on the crude model with the unadjusted model, the post-vaccination period presented an incidence rate ratio of 0.28, and the 95% confidence interval was 0.14 to 0.53. So it was a narrow confidence interval. After adjusting for sex, age, Charleston index, and current smoking at the time of inclusion on the register, the post-vac period remained on 0.25 on the incidence rate ratio, with also a narrow 95% confidence interval going from 0.13 to 0.47, and it was statistically significant. So using this model, we show that the post-vaccination period was better than the pre-vaccination one, and this is something that is only try to adjust the numbers that we already seen for the crude incidence rates. So based on these results, we can conclude that the incidence of Streptococcus pneumonia related infections experienced a decrease in RA patients taking both biologic or targeted synthetic DMARDs. And this decrease was after the introduction of the stepwise combined vaccination scheme. And this reduction was independent of age, sex, smoking, and comorbidities included in the Charson Index. So how could these findings influence the clinical practice? Well, for instance, on the recent vaccination recommendations from Euler, although it was strongly recommended to vaccinate these kind of patients for Streptococcus pneumonia, there was no clear evidence, or the evidence was not that robust for the task force to recommend either a combined scheme, the stepwise scheme, or the previous one using only the polysaccharide vaccine. So I believe these results can add to add information for future updates of it, because it looks like the stepwise vaccination scheme, the combined one, works better than the previous one. But of course, this article has some limitations. These observations might be indirect. So maybe we will have to perform future studies with different designs and to try to see if these results are consistent with these ones. And that's an area that require further focus, further research. And that was also highlighted on the systematic reviews informing these recommendations, because efficacy studies regarding vaccinations are really scarce, and most of the time we rely on the appearance, on the zero conversion after vaccination as a surrogate of efficacy. But in this subset of patients, we really need to have more information about the real impact of it, and to be able to, for instance, in these recommendations, to really said to our colleagues that you should do that, and we strongly believe we should implement this kind of vaccination because we have the right amounts of information. We have robust evidence to certainly recommend that. That will be all from my side, and thank you for your attention.
Now back to Professor Winthrop for our final presentation on the response to pneumococcal vaccination in patients receiving open-label upadacitinib.
Okay, so I'm Kevin Winthrop, and I'm a professor of infectious diseases at Oregon Health Science University in Portland, Oregon. Presenting very quickly a study looking at pneumococcal vaccination responses among RA patients who've received upadacitinib, or who were receiving it in a phase 2 open-label extension study. Alan Kivitz was a senior author, and I was the first author. This is being presented at the ACR Convergence Conference in November, and I'm happy to give you a brief overview. This was, the intent of the study was just to make sure that patients on upadacitinib had adequate responses to Prevnar 13, which is the conjugate pneumococcal vaccine. This is, of course, the newer vaccine for adults in the last 3 or 4 years. And it is recommended to start the pneumococcal vaccine series with this vaccine. And we took a number of patients who were receiving either 15 milligrams UPA or 30 milligrams of UPA in this LTE. Again, they all had RA. Most were using methotrexate concomitantly, in fact, almost 95, 98%. And the number of patients using corticosteroids was about 50% in each group, 42% in the 15 mg group, and 50% in the 30 mg group. Again, these are small numbers. The overall study only had 87 individuals in the UPA 15 group and 24 of the UPA 30 group. As we looked at their vaccine responses, you can see that at week 4 and week 12, the responses held up between those 2 time points. These are weeks after the time of vaccination. In the UPA 15 group, you can see that the proportion of patients reaching a satisfactory response, which was defined as greater than 2-fold increase in the antibody concentration in at least 6 out of the 12 pneumococcal antigens, you can see that a greater percentage of people reached that outcome in the UPA 15 milligram group, both at week 4 and at week 12. Although you can see that the proportions are very close and they're not statistically different. So about 67.5% in the UPA 15 group and 56.5% in the UPA 30 group reached that outcome measure at week 4. In terms of looking at it by antigen, 1, 3, 4, or serotype, pneumococcal serotype, there really wasn't much difference here other than what we'd expect. We see a range of geometric fold responses at each serotype, and this range between roughly 2-fold increases to almost 8-fold increases depending on the serotype. And in terms of safety, the vaccine was well tolerated. There was really very few adverse events and no difference between group. Interestingly, we did look at this according to background steroid use, because again, we had about 50% of individuals in each group that were using steroids. And we really didn't see any negative effect of steroids, which jives with what we've seen in other vaccine studies where patients using low-dose steroids do not seem to have a negative ability to mount a vaccine response. Now, of course, I will stress that these are low-dose steroids. Most of these patients are on 5 milligrams on average, but they're all less than 10 milligrams per day. And if you do studies looking at higher doses of steroids, you do see a diminished effect in immunogenicity to various vaccines. So in conclusion, we saw a reasonable proportion of patients developing satisfactory humoral immune responses to PCV13 in both groups, and the response was slightly higher in the 15 milligram group. Remember, nearly everyone was on background methotrexate in this experience. Based on other data from other studies and how we know methotrexate can influence vaccine responses, particularly pneumococcal vaccine responses, I would expect if patients were not on methotrexate, we probably have even higher proportions of patients with satisfactory responses. There is data with the pneumococcal vaccine where if you stop methotrexate for 2 weeks at the time of vaccination, you certainly can see an increase in pneumococcal vaccine responses. Now that's a polysaccharide vaccine. This is the conjugate vaccine, but I'd expect probably something similar here, but no one has done that study yet. But my hypothesis would be that holding methotrexate in this setting would also be beneficial. Lastly, just again, the responses were slightly better for 30 versus 15, but they were pretty close. And again, low-dose steroids did not negatively affect the ability of the host to respond to this vaccination. So that's it. Thanks very much for listening. Cheers.
Thank you for listening to this edition of Insights at ACR 2020. Make sure to subscribe to the CSF podcast channel on Apple Podcasts, SoundCloud, or wherever you get your podcasts from, so you don't miss out on our other ACR 2020 content, like our condensed daily highlights of the ACR Congress. If you found this informative, why not listen to our regular podcasts, which include author interviews and a monthly review of the latest cytokine signaling papers, hosted by the CSF chairman, Professor Ian McInnes. You can also visit cytokinesignaling.com for access to a wide range of free educational resources, including monthly slide summaries of the latest papers and accredited CME courses.